Welcome to Hematology Deep Dive. Uh, Today we are presenting a tricky and a rare cause of eosinophilia. I'm Dr. Enes Msekwa, together with Dr. Walter Nyamayaro. Uh, we know that the Blood Assay Foundation is bringing today blood assay together with the University of Stellenbosch and the strategic partnership with South African Clinical Hematology Society, as well as South African Stem Cell Transplant Society. And this is the team leader, which is Prof. Estelle Verbach, and coordinator, which is Dr. Gerdien Kritzinger, and our National Outreach Officer, which is Nicole Smith. Housekeeping rules. Recordings are all available for all the sessions, and please feel free to add any questions or comments to the chat box during the meeting, and we will respond to them at the end of the presentation. The CPD points will be submitted to HPCSA for each registered South African attendee. Please ensure you are attending with your own registered Zoom link and not in a group. You attend for at least an hour, and your HPCSA number is entered correctly when you sign up for a deep dive. You can join our mailing list via website resources and subscribe to Deep Dive, or use this QR code that you see on the side. Feedback is important to Blood Assay and the speakers. Value your honest feedback. Please complete anonymous feedback assay at the end of the Zoom meeting. So today we would have a presentation. I will start first with the case, and then Dr. Walter Nyamayaro will continue with the rest of the presentation. Then we'll have a Q&A, and then we would have a closing. So who is Dr. Enes Msekwa? Who am I? So I'm a senior lecturer at Haematology, affiliated with Stellenbosch, as well as NHLS. I have BSc and MBCHB from University of Pretoria, and as well as a FC Path and MMed from University of Stellenbosch. I have an extensive I have extensive experience in laboratory hematology, and also interested in medical education research. My contribution include development of online morphology training course, which we started during the COVID-19 pandemic, and aiming at enhancing diagnostic skills, especially morphology, amongst medical laboratory technologists, scientists, and as well as the junior registrars in Western Cape, and now we have moved to Eastern Cape province as well. I'm deeply committed to advancing the field of hematology in South Africa. Dr. Walter Nyamayaro is a senior supernumerary registrar in hematological pathology at Stellenbosch University. He obtained his MBCHB degree from the University of Zimbabwe. He worked at Parirenyatwa group of hospitals in Zimbabwe, where he developed a special interest in hematology. Just for important is for next week, we would have Prof. Adam Bach, who will be talking about the CML in terms of the morphology, metaphases, mutations, medication, as well as measurability of the CML. So without further ado, I will load my talk for today, and I hope everyone can see the talk.
Yes, we can see. It looks good.
Oh, thank you. So what we will be looking at, we're hoping that the key learning points will be to know the biology, or to understand the biology of hypereosinophilic syndrome, also to look at the stepwise diagnostic approach and some key investigations, to look at some pitfalls and how to avoid them, and just briefly looking at the treatment strategies and how to follow up these patients with this disease. So our patient is Mr. LK 44-year-old male, HIV negative, hypertensive, presented with chest pains, fatigue, palpitations, fever, and night sweats. He had bruises on his skin, also had splenomegaly, and also was diagnosed with loophular endocarditis, which was the main reason for him to have a bone marrow. Some of the past medical history, he was exposed to malaria treatment. We don't know, we're not sure of when was that, but it's long time. And in 2000, he was treated for meningitis and also had a hearing loss. So on his FBC, the reason was referred to us together with the diagnosis that he was diagnosed with. He presented with a hypereosinophilia. So if we were to look at from 2022, go into my left, we can see that he actually has a low normal platelet count with 6 occasions of slight thrombocytopenia. However, the rest of the counts were fairly normal, except that around June, he presented with just one incidence of slightly low HB. When we look at his differential count, we can see from the right side to the left side, in 2024, he had a lymphopenia with one occasion of a normal lymphocyte count. He also had monocytopenia with 3 occasions of normal monocyte count. Then he had persistent hypereosinophilia throughout, and he also had one incidence of basophilia. Some of the other tests that were done for this patient, they did a bilharzia test, which was negative, stools negative, other parasites were negative. He had malaria test, which was completely negative, and his IgE tests were completely normal. When we look at his peripheral film, his neutrophils and red blood cells and platelets were normal. However, when we look at the eosinophils, we could see from the image on the left that the size between the two eosinophils, one is normal size and this is a large size. And if we look at the image here, we can see this has got vacuolations as well as multiple lobes. Together with the next image, we can see it's got increased number of lobes. If we look at the image on the lower side, we will see the size between the two eosinophils, one which is small and one which is large. And on the last one, what we can see is that they have nuclear abnormalities as well as hypogranulations. So just to quick wrap on what we look for in terms of a morphology of eosinophils, most of the eosinophils are usually mature. They have a range of abnormal morphological features, which include abnormal granulation, cytoplasmic vacuoles, of which our patient had, abnormal nuclear lobation, which our patient has, and increased in size. When we see these isolated cytoplasmic abnormalities of eosinophils, they are not really related to a specific conditions. And the absence of eosinophil dysplasia generally favors a reactive eosinophilia. We did the bone marrow for this patient, and the aspirate was adequate and hypercellular, as you can see, and there was a good fallout of trails. The trilineage hematopoiesis was preserved, which increased eosinophils, which we counted 24% of the myelogram, as well as there was no increase in plasma, in blast or atypical lymphocytes. However, there were occasionally mast cells with abnormal morphology that were noted. However, the total count of the mast cells in the myelogram was less than 1%. So in this image, we will see, this is an image which shows the megakaryocytes, and we will see one of the mast cells which looks spindle-shaped. And in the image above, the one I was showing, you can see one of the mast cells which also looks spindle-shaped. We look into the next slide. We can see all these mast cells that are seen here. Most of them are spindle-shaped, and some of them shows hypogranularity. And all these spindle-shaped mast cells were counted to be more than 25% of the total mast cell count. And we can see with this image as well that we can see the hypogranularity and the spindle-shaped mast cells. Just for interest's sake, to look at the morphologic spectrum of the mast cells, we know that a normal mast cell would have a round or oval nuclear clumped chromatin, as we can see on this picture, and with the absence of nucleoli. And the neoplastic ones would be probably spindle-shaped, they could be hypogranular, or they could be multinucleated. We also have a group of mast cells which are regarded as well-differentiated mast cells. They're usually round and hypergranulated and minimal atypia. We also have immature forms in terms of blast-like. You can see on the image on your right. And also we can have the pro-mastocytes, which you can see it on the right, which usually they have a nuclear pleomorphism and may appear in children with a cutaneous mastocytosis. Looking at the trephine, it was a good trephine, adequate 45 millimeters long, and it was hypercellular for age. The architecture, however, was disturbed by multifocal and interstitial infiltrates of mast cells. We can see these areas that looks disturbed. When we look at the high power, we could see these infiltrate areas that appears like a granulomatous or granuloma structures. We can see this is more interstitial. We can also see on this picture as well. And we look at this picture as well, we can see some were paratrabeculae, some were within the lymphoid aggregates, and others were around the blood vessels. These are all blood vessels. Looking at the challenges when you're looking at the mast cells, normal or reactive mast cells may resemble histiocytes or fibroblasts, and they may aggregate around the blood vessels, which we have in our case, and the infiltrates may appear like a granulomatoid. And what is important again is to highlight these mast cells and confirm the infiltration using a tryptase or CD117. In our case, we had CD117, which highlighted these mast cells, and we could see them surrounding what looks like a blood vessel in this image. We can see there as well. We can even see here next to the trabeculae. We can even see here a clear blood vessels as well. Another one, we can see this area as well. And then these were multiple aggregates that we could see. And in the next image as well, we can see some that were surrounding one of a small lymphoid aggregates. And these aggregates of infiltrates were consisting of more than 15 mast cells in one aggregate. And the lymphoid aggregate was interpreted as reactive. So this is, we would like to have a poll, and please uh, uh, participate to the question that are put there on the poll. And then we will see what you would have done. So in our case, this is what we would have done. And if you have done, maybe we can just close the poll because it's not going to allow me to move to the next slide.
Got about 16 people of 100 so far. And it is anonymous, so feel free to vote. No one's going to judge you.
Yep, it's not, yep.
Still a few more people that are voting. Last 5 seconds. 3, 2, 1.
Okay, thank you. Do you want to remove it, Nicole? Nicole, you want to remove the poll?
Oh, sorry, I removed it from my side. I think you have to close it on your screen as well to carry on.
Okay. Okay. So what did we do in our case? We did a CD30 where it actually showed faint positivity of highlighting occasional mast cells which were well circumscribed and round or oval in shape, and it was negative for spindle-shaped mast cells. So just to give the summary, just to give an information on the mast cells in a bone marrow, all mast cells would express tryptase or KIT or CD117. Aberrant expression of CD25 and 2 and 30 will support neoplastic ones. And the reactive mast cells lack CD25 and 2, and CD30 often seen in well-differentiated systemic mastocytosis. KIT mutation is important to support the diagnosis of mastocytosis. We did FISH for PDGFRA, which was positive. FISH for PDGFRB was negative, and for FGFR1 was also negative. The T-cell gene rearrangement was polyclonal. The IgH gene rearrangement was negative. We did send a sample for NGS myeloid panel. Unfortunately, it was rejected, or rather not done, and serum tryptase was rejected by an accident. However, we're not going to discuss the reasons for what happened with the sample. This is one of my last poll. If we want to put it in for the people to pick what they think could be a diagnosis at this point in time.
Looks like most people have finished, so I'm gonna end the poll.
Okay. Okay, so I will allow Dr. Walter Nyamayaro to continue with the rest of the presentation. Walter, please load in your slides.
Okay, Nicole, can you load my slides? I'm already sharing.
Yes, we can see them. It looks good.
Okay, good. Sorry, something happened to my screen. Just give me a minute to figure it out. Okay, good. Good afternoon to you. My name is Dr. Nyamayaro, and I'm a registrar in the Department of Hematology Pathology. So this afternoon, my task will be to talk about an approach to hypereosinophilic syndromes. And in the end, I'm going to zero in on our main differentials. So this is going to be how the discussion is going to be structured. I'll talk about the biology of eosinophils, hypereosinophilia and hypereosinophilic syndromes. Then we'll go through the classification and approach to hypereosinophilia. Then in the end, I will zero in on the two main differentials, which are the myeloid lymphoid neoplasia with eosinophilia and defining general rearrangements, and also systemic mastocytosis. Then towards the end, we'll just give a brief talk about the guidelines, treatment guidelines. So eosinophils are a type of granulocytes that function as first line of defense against parasites, and they are also involved in allergy reactions. And these are derived from the hematopoietic stem cells via the common myeloid progenitor cells, which also gives rise to the mast cells. And transcription factors that are important for the maturation and differentiation include GATA1 and GATA2, as well as cytokines such as interleukin-3, interleukin-5, and also colon-stimulating factor. This process of maturation from hematopoietic stem cell to a mature eosinophil takes about 6 to 7 days. And the mature eosinophils, they enter peripheral blood from the bone marrow, and they circulate briefly in blood for about 8 to 18 hours. And about 5% of the total eosinophil constitutes the circulating pool. Then from there, eosinophils, they take residence in different tissues. Eosinophils are essentially tissue resident cells. So a normal eosinophil is a size of about 14 to 16 micrometers in diameter, and it contains about 2 lobes. The cytoplasm is clear with large eosinophilic granules that do not obscure the nucleus outline, and also there are no vacuolations. Eosinophils may show abnormal morphology in reactive or neoplastic conditions, and generally it is difficult to distinguish between reactive and neoplastic eosinophils, but both of them can show variations in size, as Ernest has explained, changes in cytoplasm, such as abnormal granulation and also cytoplasmic vacuolation. And we can also have nuclear changes such as hyperlobulation and also ring forms of eosinophils. Hypereosinophilia is defined as an absolute eosinophil count of 1.5 times 10 to the power 9 eosinophils in peripheral blood, measured on 2 separate examinations, which are 2 weeks apart. And tissue hypereosinophilia is when there's extensive infiltration of tissues with eosinophils, and particularly in terms of the bone marrow. The eosinophils comprise more than 20% of all nucleated cells in the bone marrow. Then with hypereosinophilic syndrome, this is hypereosinophilia with end organ damage, when all other causes of organ damage has been excluded, and the end organ damage is only attributable to hypereosinophilia. Then tissue restricted hypereosinophilic syndrome is tissue hypereosinophilia without hypereosinophilic syndrome, and with end organ damage associated with hypereosinophilia. Eosinophilia may be classified into 4 categories. The first category being familial eosinophilia, which may occur with or without immunodeficiency. Then it can be secondary or reactive to hematological or non-hematological conditions, such as parasites, infection, allergic reactions, and also some chronic inflammatory processes. And the hematological causes of reactive eosinophilia essentially lymphoid diseases. Then primary or clonal eosinophilia usually arises from myeloid neoplasms. And when no cause can be found, eosinophilia can be classified as eosinophilia of unknown significance. This table shows the hematological neoplasms associated with eosinophilia as Hodgkin lymphoma, or mature T cell neoplasms, lymphocytic variants of hypereosinophilic syndrome, and also T and B lymphoblastic leukemia lymphomas. Then we've got clonal causes of eosinophilia, such as myeloid lymphoid neoplasia with eosinophilia and defining gene rearrangements, certain types of acute myeloid leukemia, mastocytosis, myeloproliferative neoplasms, and also myelodysplastic neoplasms. This diagram just shows organs that are potentially involved in patients with hypereosinophilia and also hypereosinophilic syndromes. Important to note is that organ involvement depends on the underlying etiology. And in patients with hypereosinophilic syndrome, multiple organs can be involved, but also single organ involvement in eosinophilic colitis, and eosinophilic gastritis can be seen. This table shows a clinical approach to eosinophilia, and it shows that patients may present with different symptoms and signs and affecting different organ systems. A good history and also physical examination and initial investigations with FBC, blood film, and some inflammatory markers may help to identify possible etiology of eosinophilia. And some of these patients may need referral to different specialists. And please note the red flags that warrant referral to a hematologist. That is, if there are symptoms of end organ involvement, especially cardiovascular and neurological. We've seen in the case of our patient that the patient was referred to hematology because the patient had left endocarditis. And also, if the blood film shows abnormalities that are suggesting of hematological neoplasm, such as an increase in blast or there's a dysplasia on the film. So WHO and ICC approach to investigation of eosinophilia. So essentially with a negative screen for secondary causes of eosinophilia, and with a thorough assessment of end organ damage that has been done and completed, the next set of investigations that we may do is to do serum vitamin B12, which may be elevated in some conditions of myeloproliferative neoplasms, serum tryptase levels, which may be increased in systemic mastocytosis, and also serum IgE levels may help to distinguish between reactive and neoplastic causes of eosinophilia. Normally, in reactive causes, serum IgE levels are increased, but in neoplastic eosinophilia, it may be normal or even decreased. Then bone marrow biopsy is essential for morphological assessment of blast dysplasia or fibrosis, and also flow cytometry. Then cytogenetics and next generation sequencing are also very important. Conventional karyotype is able to determine most of the myeloid lymphoid neoplasm associated with defining gene rearrangements as shown in this box. And this can also be confirmed on NGS, FISH, or PCR. However, for the PDGFRA fusion rearrangement, this is cryptic, so it is not visible on conventional karyotype. Hence, it will need FISH, a quantitative PCR or NGS to detect. Then a search for myeloid neoplasm is also mandatory, as well as to do flow cytometry so that we can identify abnormal T cell populations, which, if identified, may be followed by PCR for T cell gene rearrangement to determine the clonality of these T cells. If all the investigations have been done and no cause can be attributed, and there's no end organ damage, then the patient can be classified as having idiopathic hypereosinophilia. However, with end organ damage, the patient can be classified as hypereosinophilic syndrome. So I'll now zero in on myeloid lymphoid neoplasia with eosinophilia and defining gene rearrangements. So this is a group of neoplasms which are classified by the presence of dysregulated fusion tyrosine kinase genes. And these present in various ways. They may present as myeloproliferative neoplasms, myelodysplastic myeloproliferative neoplasms, or mixed phenotype acute leukemias. So the common feature with these conditions is eosinophilia, but eosinophilia is not always present all the time. And WHO in 5 classifies the myeloid lymphoid neoplasia with eosinophilia and defining gene arrangements into 7 subgroups. And the ones that are indicated in red here show the new features that have been added in WHO 5 that were not present in the previous revised 4th edition. This table summarizes the different myeloid lymphoid neoplasias associated with defining gene rearrangements. And for the sake of our patients, our patient had PDGFRA positive gene rearrangement. So I'll mostly concentrate on this, but important to just make a comparison with the other subtypes. So with the PDGFRA, there's a 4q deletion, which results in constitutive activation of the PDGFR kinase. Then the typical phenotype for the patients with PDGFR mutation, they present like in chronic eosinophilic leukemia like picture, and they're usually middle-aged, and there's a male predominance. The peripheral blood shows marked eosinophilia, which is a feature that's shared with most other entities in this subgroup. And there is occasional basophilia, which we noted on our patient. Then the bone marrow shows a hypercellular marrow with increased eosinophil proliferation and also muscle proliferation, which we saw in our patient. The phenotype of the mast cells is positive for CD117 and tryptase, and they may appear in aggregates. Then PDGFRI would generally give us a good, excellent prognosis and responds well to imatinib, and a bone marrow transplant is really needed. This is in contrast to, for example, the FGFR1 mutation, where the prognosis is usually very poor, and rapid progression of disease without bone marrow transplant is noted, such that a standard of care in eligible patients, bone marrow transplant is the gold standard. So zeroing in on the PDGFRI gene rearrangement. So there's an interstitial deletion of a 800 kilobase pair, 800 kilobytes on chromosome 4 and the long arm region 1 band 2, and this deletion results in the loss of the CHIK2 gene and creates the FIP101 PDGFR gene fusion. We can see on the diagram on the right, this shows just a segment of the long arm of chromosome 4, which shows that the FIP101 gene is located on the centromeric site of the chromosome 4, and our PDGFRI is located on the telomeric site with CHIK2 somewhere in between. Then these 4 green bars denote the possible probes that can be used for detection of this deletion by fish. So with regards to that, this diagram shows interface fish with 3 probes. We've got the FIP101, which is represented by the aqua probe, the CHIK2 by the red probe, and also the green probe representing our PDGFRA. So a normal interface shows 2 nuclei with overlapping red and green signals that will produce this yellow signal, which shows fusion of the red and yellow and red and green probes. Then there's also an aqua probe, which is in close proximity to the fusion probes. Now, with a deletion of the CHIK2, so we have 1 chromosome showing a fusion signal, a fusion signal plus the aqua signal. Then the other chromosome, the red signal is lost. So we are going to have our green and blue or aqua signal being seen. Now, this one will show an insertional translocation of CHIK2, where we've got deletion of the CHIK from the chromosome 4. Then it goes and inserts at a different locus as well. for the diagnostic criteria of myeloid lymphoid neoplasia with eosinophilia and defining their gene rearrangements, the diagnostic criteria requires that we should have a myeloid or lymphoid neoplasia with prominent eosinophilia and one of the following. In the case of our patient did a PDG-FARA gene rearrangement. So essentially, our patient fulfilled this criteria. Then moving on to systemic mastocytosis. So this is a clonal mast cell disorder which is characterized by abnormal proliferation and accumulation of mast cells in extracutaneous organs. So the driver mutation for systemic mastocytosis is KIT D816V mutation, which is a single nucleotide variant missense mutation, which is also located on the same locus as the PDGFRA, that is the 4q12, and this is on exon 12. So the nucleotide change occurs on position 2447 at codon 806, where the A is substituted for T. As you can see, this is the codon 861 on the chromosome 4. At the position 244, there's on the wild type there's A, which represents aspartic acid. Then with the mutation, the amino acid changes to valine. Other rare mutations have also been described, such as the KIT D816H and also the KIT D816Y. And in all these mutations, these result in constitutional activation of the KIT receptor tyrosine kinase. So KIT is a receptor tyrosine kinase, which is also known as CD117. So its function, it binds to a stem cell factor, and it is also a proto-oncogene. It exists as a homodimer in the resting state, and the binding of a stem cell factor to the KIT receptor results in the dimerization of the homodimers, which results in the activation of distal signaling pathways, which results in cell growth, differentiation, and survival of stem cells, progenitor cells, and other cell types. So the KIT mutation results in constitutive activation of the KIT receptor independent of the stem cell factor, resulting in uncontrolled proliferation and survival of the mast cells. For the diagnostic criteria of systemic mastocytosis, we need major and minor criteria. So WHO diagnosis of systemic mastocytosis is one major and one minor criteria. And if there's no major criteria, then one of the three of the four minor criteria can make the diagnosis. However, with the ICC, they say when the myeloid lymphoid neoplasia with defining gene rearrangements have been carefully excluded, then the presence of major criteria would suffice to make a diagnosis of systemic mastocytosis. However, if no major criteria is present, then three of the four minor criteria are needed to make a diagnosis of systemic mastocytosis. And the major criteria comprises of multifocal dense infiltrates of mast cells, which should be positive for CD117 or tryptase. And these aggregates should consist of at least 15 cells per aggregate, that is in the bone marrow or any other extracutaneous organs that is being investigated. If there is no major criteria, the four minor criteria are of the mast cells in the bone marrow or the extracutaneous organ, 25% of those mast cells, they should be spindle-shaped or have a typical immature morphology as shown in the diagrams below. I think Enes has talked a lot about the morphology of mast cells. Then the second minor criteria is that the muscles in the bone marrow, or the peripheral blood, or extracutaneous organs, they should aberrantly express CD25, CD2, and or CD30, in addition to the muscle markers, the CD117 or tryptase. Then the KIT D816V mutation or other activating KIT mutations can also be classified as a minor criteria. Then persistently elevated serum tryptase greater than 20 nanograms per ml. And according to the ICC guidelines, which is what we're looking at, in the case of systemic mastocytosis associated with hematological neoplasm, the presence of an elevated tryptase, serum tryptase, ceases to become a minor criteria. So, which means in the cases of a suspected systemic mastocytosis and associated myeloid neoplasm, the serum tryptase, we cannot use it as a minor criteria. So once the diagnosis of a patient meets the diagnosis of the criteria for systemic mastocytosis, the next step is to try to quantify the disease burden and also the aggressiveness of the disease. And this is done through the use of B and C findings. Generally, the B findings show a high muscle burden and evidence of organ involvement without any organ damage. And we see there is myeloproliferation, and also there is prominent eosinophilia. Then with C findings, there is a high muscle tumor burden, organ involvement, and also evidence of organ damage is described in the features below. We've got cytopenias and we've got hepatopathy, splenomegaly with hypersplenism. Then, if the percentage of mast cells in bone marrow is greater than 20% or greater than 10% of the leukocytes in peripheral blood, then a diagnosis of mast cell leukemia can be made. Otherwise, we also need to search for any associated myeloid malignancy, so that we can classify our systemic mastocytosis as systemic mastocytosis with associated hematological neoplasm. Then the presence of at least one C findings qualifies the systemic mastocytosis as aggressive systemic mastocytosis. If there are no C findings, but we've got at least two B findings, this can be classified as smoldering systemic mastocytosis. And if we've got one or less B findings, then mastocytosis is classified as indolent systemic mastocytosis. Otherwise, if there are no B or C findings, then it is considered a case of bone marrow mastocytosis. With systemic mastocytosis with associated hematological neoplasm, the patient must meet the diagnostic criteria for systemic mastocytosis and must also meet the criteria for an associated myeloid neoplasia. And the associated myeloid neoplasia should be fully classified according to the established criteria. So if eosinophilia is present, the presence of the tyrosine kinase gene fusion associated with myeloid lymphoid neoplasia with eosinophilia in the defining gene rearrangements should therefore be excluded. Concurrent PDGFRI rearrangement neoplasms and systemic mastocytosis is uncommon. And in these instances, the myeloid lymphoid neoplasm with PDGFRI rearrangement would now represent the systemic mastocytosis associated hematological neoplasm. And most cases of systemic mastocytosis with associated hematological neoplasm are due to KIT mutation and not the PDGFRI fusions. The PDGFRI gene rearrangement results in the constitutive activation of tyrosine kinases, and this drives eosinophilia and mast cell proliferation, which can actually mimic systemic mastocytosis. But usually these cases, they lack the KIT mutation. Then the mast cells in these patients may be increased in number, and they may also assume a spindle shape, and also may also be CD25 positive. And this may they may appear to satisfy or to fulfill the criteria for systemic mastocytosis, but the absence of KIT mutation usually argues against the true systemic mastocytosis, and mast cell infiltrates are often less dense than the classic infiltrates that we see in the KIT mutant systemic mastocytosis. Then serum tryptase may be elevated, but this can reflect the PDGFRI-driven clone and not the true systemic mastocytosis, which is probably why ICC removes serum tryptase as a diagnostic criteria in this instance. So going back to our case, our patient had the following: multifocal dense infiltrates of more than 15 mast cells in aggregates, and these mast cells were CD117 positive, and more than 25% of the mast cells were spindle shaped in the bone marrow aspirate. Thus, the patient was fulfilling the diagnostic criteria for systemic mastocytosis. Then on the other end, our patient also had hypereosinophilia with a positive PDGFRA rearrangement, and also fulfilled the criteria for myeloid lymphoid neoplasia with eosinophilia and defining gene rearrangements. Nico, can you run the poll for us?
Yes, sure.
So what would be the final diagnosis?
Few more seconds for last people to vote. Okay, looks like everyone's voted. So 56% said MLN with eosinophilia and PDGFRA rearrangement, and 44% said SMAHN.
Okay, good. Yeah, I think we can end the poll. Do I have to close it this side?
Yes. I closed it my side, so you can just close it your side as well.
Okay, good. Okay, good. So yeah, it was almost like a 50-50 affair, isn't it? So in our case, the following differentials were considered based on the following facts. So our preferred diagnosis was myeloid lymphoid neoplasia with eosinophilia and PDGFRI rearrangement. Based on the evidence that we had the PDGFRI rearrangement gene positive. However, we could not totally rule out systemic mastocytosis with associated hematological neoplasia because we did not have the test for KIT, which is also important, though not essential, but it would argue more for systemic mastocytosis associated with hematological neoplasia. So our patient was treated as such, was treated with imatinib, and this is the follow-up of the patient. So I just downloaded the differential count We can see from the time that the bone marrow was done, we had an eosinophilia of 4.55 times 10 to the power 9 per liter. A few weeks after commencing on imatinib, our eosinophil count went down to 0.29. In almost about a month, 2 months after, the eosinophil count is still low. So in terms of treatment guidelines, how do we approach this? So the recommendation is that we need to treat the driver mutation, and imatinib is highly effective against PDGFRI rearrangements. And in cases with concurrent systemic mastocytosis and associated hematological neoplasm, the therapy must address both lesions. So if the KIT mutation is present, then KIT inhibitors such as midostaurin should be used. And if other associated hematological neoplasms are present, then we need to apply the standard regimens for such neoplasms, such as for AML or MDS. Then supportive care includes steroids for patients with, for example, eosinophilic myocarditis. Anticoagulation can be considered in patients who are thrombosing, and also mediator blockade with drugs such as antihistamines, leukotriene antagonists, and also omalizumab. Then allogeneic stem cell therapy can be considered in cases where the patient is refractory or resistant disease, or there is an aggressive associated hematological neoplasm, or in cases of imatinib resistance. So the standard dose is usually 100 milligrams of imatinib, which can be increased to 400 depending on the disease burden or if the patient is resistant. And the majority of patients who achieve complete remission, molecular remission within 3 to 6 months, and PCR is recommended for monitoring the remission status. However, unfortunately, I think it's not available in NHLS. Then resistance mutations are rare, but they've been described. For example, with the PDGFRA, that T671 as T674I, which is analogous to the BCR-ABL, the T315L, and also the D842, which offer resistance to imatinib. In these cases, alternative tyrosine kinase inhibitors need to be given, such as potanib, which is effective against both mutations, or sorafenib, which is only effective against the T674I mutation. So the take-home message is that true systemic mastocytosis is rare in PDGFRI rearranged disease. And many patients may meet some morphological and phenotypic criteria of systemic mastocytosis, but without KIT mutation, the biology may be different. The World Health Organization and ICC recommend not overdiagnosing systemic mastocytosis in this context, and it is recommended to classify such cases as myeloid lymphoid neoplasia with PDGFR rearrangement with mast cell hyperplasia or proliferation. Systemic mastocytosis with associated neoplasm, however, should only be assigned in instances where both KIT mutation and the myeloproliferative neoplasm rearrangement genes are present, or if all criteria for systemic mastocytosis are convincingly met. Thank you for your attention. So this way, my references, some of the references are shown on the relevant slides.
Thank you, Walter. Interesting and important topic, even though the two malignancies or the two differentials are very rare to be seen together in one patient. So before I open the Q&A, I just want to say what was interesting was we had a long time with the case to decide which route to go. And I just found that majority of you now, just with the poll and with the presentation, you were able to have an idea of which route to go, but still you ended up where we end up, where you have two differential and the house it's divided into two. I will now just open the Q&A for anyone with a question or comment. There were some questions on the chat, which maybe I'll just mention them for everybody so that you don't have to repeat them. There was a question from Nicole asking about a visual morphology training that we do here in Tigerberg, if this involves registrars outside Western Cape and Eastern Cape. Of course, yes, the aim was to move from one province to the next. Now we are in Eastern Cape, and we would like to move to other provinces if people are interested. And the next question amongst that was, how do people sign up? We usually use the area managers and the business managers as well as lab managers to tell them that we have this course, and then if they have technologists or scientists that are interested, we haven't been thought of giving it to other registrars outside our department. However, this is a good thing for junior registrars who are starting, who would like to attend it. Just to say a little bit, I'm not sure if I'm selling something else that has nothing to do with the topic for today. It's got two sections. You do get slides from us that we send you to enter your morphology, and then we mark it. Otherwise, I'll open the Q&A section for anyone with a burning question or a very good question or comment at this point in time. While we are waiting for anyone to say something, Walter, if you see the way in terms of systemic mastocytosis, where it talks about the B findings and the C findings, and we saw that the patient had splenomegaly, which is, I think, is one of the B findings, and also patient didn't have a clear cytopenia, but one can argue with it. So if you probably can go back to that slide just to explain why probably we didn't go with either of the B or C findings. Walter, are you still there? Yeah, yes, I think that's the slide, yeah. I think you're muted, Walter. We can't hear what you're saying.
Okay, so I think in terms of our B and C findings, our C findings refer to high tumor burden with evidence of organ involvement and organ damage. So if we go and look at the full blood count of our patients, there were just isolated episodes where there were occasional cytopenias, probably not enough to make it the criteria for cytopenias for B symptoms. And also the hepatomegaly without
Splenomegaly.
the splenomegaly without hypersplenism probably would qualify as organomegaly for B findings. However, as one of the findings for the B findings, we need the bone marrow to have more than 30% mast cells on histology. Our patient had very low mast cell percentage. I think it was less than 1%. So the splenomegaly may actually not make it as a B findings, and it may actually be attributed maybe to the eosinophilia, probably driven by the PDGFRI gene rearrangement.
Okay. While we're still waiting, if probably what would be other maybe recommendations in terms of extra investigations for this case to be complete that you will probably want to be done, if there are any to consider?
So we could also consider doing skin biopsies, and look for muscle infiltrates. We can also do liver function tests so that we can also look for organ damage. Flow cytometry will be important so that we can roll out or look for some lymphoproliferative neoplasms. Then also lymph node biopsies, if there are any palpable lymph nodes, they can be sent for histology. Yeah.
Okay, thank you. Now the floor is open for anyone. Okay.
Will someone speak? Oh,
Yes, Prof, you can speak. Yes, speak, Prof.
no. I was just saying it was silent. Sorry. Keep going.
I was just giving anyone with a comment or a question to just speak. It appears as if everyone went through the case very well and the presentation as well. And I think what actually helped was that after the case, the presentation actually clarified which route to go, because it dealt a lot with the criteria and the nitty-gritty of what to say, what to use when you're diagnosing either one disease against the other one. So it was a tough case in the beginning because we didn't have all the investigations. And however, with what we see now, based on also the patient response to the treatment, we more likely can assume now that the driver mutation now is probably the BDGFRA rather than the KIT mutation. However, without having the results of KIT mutation, it's a hypothesis that we can hypothesize that based on the results that we're seeing of the patient's treatment. It would have been nice to have that test, however, but you could be faced with this in a place where you don't have an access to NGS or even special molecular test. So you can still make a call when you have a case like this one using the tools that you have available. I see there's a question from Yasmin. It says, thank you for a brilliant talk. Are there any clinical differences between well-differentiated systemic mastocytosis and classic systemic mastocytosis? Walter, you want to answer that one?
I'm not 100% sure if there is any clinical differences. I can tell of maybe diagnostic or laboratory differences where normally with our well-differentiated systemic mastocytosis, the morphology of our mast cells is usually round as opposed to the spindle or typical with our classic systemic mastocytosis. And patients with well-differentiated mastocytosis, usually they tend to have positive CD30, and the KIT mutation is usually negative in such patients. But in terms of the clinical features, I'm not 100% sure that there are differences. I'll probably have to look that up.
but what I would think is because you be having these malignant mast cells, I think still they will still give you some of the B findings and also the C findings either way. And the diagnosis will be based on the bone marrow or the morphology of the cells to choose whether is it the well differentiated ones or is it the classic ones. That's okay. Yeah, thank you. Anyone with any other questions? We are still have some time to discuss anything related to today's topic. Just to remind everyone that the next week hematology deep dive will be about CML, and please attend as you normally do. We had a large number of people attending, I think 100 plus. Otherwise, don't know if I'm gonna close it unless you have one pending question. Gonna count 5, 4, 3, 2, 1, and otherwise, thank you everyone for attending. Thank you for giving us this platform to show you the case and discuss the biology of mast cells as well as eosinophils. Thank you everyone, and we'll see each other again next week. Thank you,
Thank you,
Nicole.
everyone.
Thank you both. Great talk.